Good morning, everybody. I hope you can hear me. Dr. Frank Atherton, I'm the Chief Medical Officer for Wales, and I'm here to just welcome you to this conference. Absolutely delighted that so many of you have been able to join us, and thank you ever so much for your patience while we sorted out a few technical glitches, unsurprisingly. Very keen to make sure that it's not just Donald Trump who is able to tweet. I know you all can, so I'm encouraging you all to use the hashtag ResearchWales20 as you tweet. We've managed to trend in this conference over the last 3 years, and it would be good to carry on doing that again. This year obviously is very different to our previous conferences. They've become quite an annual fixture in the calendar. This is the first time, of course, we've run a virtual conference, and we're all, of course, on a learning journey, hence the slight delay this morning. You know, one thing I would say is that, you know, as we've been going through this coronavirus journey that we've all been on for the last, 9 months or so, you know, there have been some unexpected bonuses. And one of them is that we actually have a much higher attendance at the conference this year. Over 800 people registered compared with 300 that normally attend. So that's a really positive thing. And I might reflect a little bit on that again later. A couple of things. I'm chairing this session, but because of the technical glitches, I'm doing it through Teams rather than Crowdcast. I know that's what you're all using. The advice I always have to pass on to you is that if you have problems with your connectivity, basically log out and log back in. It's basically the IT rule of turn it off and turn it back on again. But I probably guess you could have figured that out anyway. We are going to have two excellent speakers shortly, and we're going to take questions as usual. Again, one of the kind of benefits of moving to this kind of technology is that we avoid that awkward moment where, you know, we wait for questions and for the first brave soul to put a hand up. We don't need that, because you're able to put your questions onto Crowdcast on the bottom bar, and you're able to vote other people's questions up the list as well. So please take advantage of that as we go through the presentations in a moment. And the final thing just to mention is a preamble is that we do, at the end of the final plenary session this afternoon, there are prizes to be given out. We do have prizes for public involvement achievement, for the best oral presentation, and for the best exhibition. So keep an eye on those, and feel free to vote on those, please. Now, what I wanted to do in just a very brief time, and I will be brief because I know we're a little bit late getting started, and then I'm going to hand over to Kieran Walsh, who many of you will know, and he will introduce the speakers and take you through the presentations. But I wanted just to welcome you, the research and development community, because it has been a very difficult year, you know, and I think looking forward, looking into the next few months, I am absolutely certain that COVID is going to continue to dominate as it has done for the last few months. It's been an extraordinary year for all of us. You know, it's been the busiest and most challenging time of my professional career, and I'm sure many of you feel the same. So that is going to continue to dominate. We are trying to prepare our public, I think, for a very difficult winter ahead. You know, not only do we have coronavirus here, we also have the prospect of Brexit looming. You know, towards at the end of the year, the extension period will come to an end. So that's going to challenge us as well. And you know, we're getting into flu season now. We hope flu season will be mild. It has been in the southern hemisphere, which is good news, but we can't take that for granted. So there's a lot of you know, risk in the system, a lot of threats and worries, but there are some positives, you know, and I try to reflect on some of the positives that come out of coronavirus, and one of those is that you know, we've managed over the last few months to do things in a very different way in the health and care setting. We have been fleet of foot. You know, we've got new IT into primary care. There are some population health benefits as well that we're seeing. You know, working from home, people cooking more at home, people able to use IT platforms much more effectively, and you know, some broader population outcomes. we can expect from lower air pollution, for example. So there are positives in all of this, and we need to keep a review on those. And one of the real positives that I've seen over the last few months has been around the ability and the willingness of the research and development community to really step up to the mark and to play a huge role in tackling coronavirus. It is research and development that will find our way out of this. You know, we are muddling through, I think it's fair to say, a very difficult and changing and rapidly evolving situation, and research and development is absolutely critical to finding our way through that. Not least, of course, through the development of a vaccine, but also through treatment and through understanding what is happening and who is being impacted by coronavirus. There are two reports that we're publishing today. One that are being published today. One is the Making a Difference report, the impact of health and social care research in Wales, and there are case studies in there that you will see around the benefits that come to cardiac patients who have been managed through critical care, but also the fact that we in Wales are very actively involved in the Oxford University vaccine trial. For example, we're very involved in convalescent plasma trials. We've been at the forefront, actually, of genomic studies. I can't remember whether we're the second, third, or fourth, but we're way up there in terms of the number of countries, the number of genomic assays that we've run on coronavirus globally. So we're having a huge impact way beyond the size of Wales, really. So that report hopefully gives a flavour of some of the research and development that's going on and that is having an impact. You know, back in the kind of early days, in March, April, when we were really fearful that the NHS was going to be overtopped, that we would not have sufficient capacity. The survival rate of people going through ITU systems was about 50-50. You know, if you went into ITU, broadly speaking, you had a 50-50 chance of coming out alive. That's changed, and that's changed because of research, the dexamethasone trials, you know, and other therapeutics that are coming on stream now as a consequence of the research community that is reducing death rates significantly. And the second report, you know, that's being produced today is by KPMG, commissioned through Health and Care Research Wales, and looking at the economic impact of our R&D spend. You know, £43 million roughly that we spend a year on research and development. Not a huge amount in Wales, but the return on investment for that is enormous. We estimate £93 million in GPA and about 1,600 jobs being created. So the economic consequences and benefits are really huge as well. So I'm delighted to see the health and care research community working so hard to support the coronavirus and moving forward to drive economic recovery here in Wales. I really believe it is the time to shine for research and development here. I have consistently worried about the fact that we are underfunded in Wales compared with other UK nations, and I think there are opportunities in the roadmap for research and development that BEIS has produced recently to try to correct that. So we're working very hard to try to seize some of those opportunities. When I think about the research and the research and development community, I do think very broadly. I mean, you know, we tend to think about our lead researchers, our specialty leads in health, but you know, the centres that we run, the units that we run here, the R&D offices in all of our health boards, the support and delivery services through Health and Care Research Wales, all of these are critical in coming together. So it's great to have the opportunity to come together, even in this virtual format. I know everybody's going to miss the opportunity over the next day or two to engage socially and to do that networking that is so important to us. But hopefully the IT will help us allow some of that to happen. Finally, really, I just wanted to make a comment that you know, we don't work on this alone. Our research and development has to be done in partnership. It has to be done alongside the many other organisations we work with, NIHR, of course, the other devolved nations, and their efforts to rebalance the R&D budget is really important. And you know, funding with the charities, Cancer Research UK, Scarcity Foundation, etc. So we don't do this alone. We do this in partnership. I am immensely grateful to everybody in the health and social care research community for the fantastic work you've been doing over the last 12 months, and particularly over the last 9 months during coronavirus. Your efforts do not go unrecognised, and the impact of your work is and will be huge going forwards. That's really all I have to say. I'm going to hand over now. I was going to chair this session. I was really looking forward to chairing the session with Simon Denegri and Usha Bulaki, but I have to hand over to Kieran Walsh to take on that pleasant duty, and I wish you all well over the next period of the conference. Very good luck, and thank you for everything that you continue to do.
That's great, Frank. Thank you so much for that introduction. It does fall to me to introduce our two speakers, and just to say briefly, Simon and Usha are each going to speak for about 10 or perhaps 15 minutes, and we'll run those two straight up, one after each other, so that then we've got time at the end for lots of questions and discussion. There's a button at the bottom of your screen to ask a question, and when you click on that, you also see other people's questions and upvote them, and that's really helpful to me and to Simon and Usha in working out which questions to respond to and so on. So the theme of the session is really about research capacity and culture. Simon, I'm delighted you could join us, Simon. Simon's the director of the Academy of Medical Sciences. I think many people in the room, so to speak, will have read the Academy's report that came out looking at research culture and research capacity in the NHS. That's very close to Simon's heart. Simon, previously, I think many of you will know him from his work for NIHR, leading on patient and public involvement and chairing Involve. So Simon's going to speak first, and then we'll turn to Usha Bulaki. Usha's Assistant Director of Research at the Health Foundation, is on the board of HSR UK. The Health Foundation, I think, is a really important independent funder of a wide range of health research, and Usha will come to this very much, I think, from that funder's perspective. So without further ado, I'm going to hand over to Simon first. We'll transition straight from Simon to Usha. I gather Usha's camera isn't working, and that means she'll be presenting, but you won't be able to see Usha. And then we'll move to the Q&A at the end. So do think, as you're hearing Simon and Usha speak, do think about questions or issues you'd like to raise. Simon, over to you.
Great, thank you very much, Kieran, and good morning, everybody. It's a real thrill to be with you. I've been seeing the numbers of people in the conference climbing, and I think we're just about to reach 350. So that's absolutely fantastic. So yes, I'm the Executive Director of the Academy of Medical Sciences. I've been there about a year, and it's been a very quiet year, as you can imagine. And previous to that, I was the NIHR National Director for Patients. It might also be worth adding that since April, I've been the chair of the executive group of the UK Clinical Research Collaboration Clinical Trials Unit executive group. So I have some sense of the issues and themes that are cropping up, particularly around things like the restart agenda for clinical trials. And I'm really pleased to have the opportunity to talk to you this morning. I do have some slides, and I think the technical people are in charge of those. So let's go to the first slide. Before I go into talking about the report that Kieran has mentioned, let me just tell you very, very briefly a few things about the Academy, because you may not all know anything about the Academy of Medical Sciences. So we were established in 1998. We're the youngest of what they call the national academies. We are composed of a fellowship of 1,300 fellows from across all the medical sciences. We have a much wider community as well of early career researchers, many thousands of early career researchers who've benefited from our grants and schemes over the years. We spend about £10 million on grants and different sorts of schemes. Some of those you may have heard. So we do a very good mentoring scheme. We've just put together our 1000th mentoring pair since we began many years ago. So quite an achievement. We have 4, I suppose, main areas of work: supporting researchers' careers throughout their lifetime and helping them become independent, influencing policy across the UK, involved administrations as well as the British government, promoting public engagement and actually engagement with professionals, the wider professional groupings as well, and also promoting excellence, primarily through our fellowship, but in other ways as well. And our mission is very much to advance biomedical and health research and to see its benefits translate into impact for society and populations and the diverse population that we have across the UK, but also globally. So that's a little bit about the Academy, and as I say, delighted to come to you this morning and talk about our work. So next slide, please. I did want to take this opportunity to really speak about, as Kieran says, the report that we published in January called Enhancing the NHS Academia Interface. It was a report that came out and was very, very well received. I think one of the reasons that it was well received and really well covered is the fact that we had such a lot of support from partners across the UK, including NHS Wales and others. And I know that colleagues in Wales have been promoting it very actively. We have a regional champion in Wales, some of whom may know her, Julie Williams, but I know we have many other colleagues who have been promoting the report and its findings. And so today I think it's very much about trying to pick up the story behind that report and where we had got in promoting the key conclusions and recommendations. Because of course February onwards the pandemic took hold and some of the work that we were doing has become was interrupted, but we've been able to pick that up since the early autumn. Next slide, please. So just to give you a bit of a background to the report, the case for research in the NHS and wider health and social care system is well made. I'm sure you are very articulate in putting it across to others, but we have some amazing strengths and assets within our system in terms of our international reputation, our infrastructure, our research active healthcare settings, and growing evidence of the impact of research on patient outcomes. But we also have, and they seem to be age-old challenges for someone like me who's been around this agenda for 20-25 years, that we still grapple with lack of capacity, decline in the number of clinical academics, widening gap between perhaps academia and the NHS. And it was really with this combination of opportunities and challenges in mind that our president, Sir Robert Leclerc, felt that he wanted to convene and catalyse some work which brought together a cohesive plan for trying to address this and bringing NHS academia and the many other partners around research together into a unified manifesto, if you like, a manifesto and approach for working through some of those issues and finding solutions. Next slide, please. So following a working group of several months, we developed a report, and this is the vision in that report and the main objectives. We made sure that we aligned very closely by working with partners and talking with colleagues before the publication of the report, that it was aligned with the growing policy agenda and policy plans that were coming out, whether it be the long-term plan or people plan. But it also aligns very closely now with the R&D roadmap that you may have seen emerge from Bayes, but also the key themes that have been signalled in the comprehensive spending review. And I'll come back to the comprehensive spending review a bit later. So we feel it very much is a part of the delivery of the research agenda over the next 5 to 10 years. And that's what we tried to communicate in our vision and our call for urgency. Next slide, please. As part of the report, we brought together many case studies and good practice that you can find in the report on the website, and you can find a web link there. Some of those case studies are from Wales, and we are constantly on the lookout for new case studies or news about how existing ones have evolved and new learning from that, so we can add those to our website. We do see ourselves very much as hopefully a place that people can come to and learn more about how this agenda has been furthered. But the report, next slide, please. But the key part of the report was focusing on these six areas, rather. Well, number one, creating a healthcare system that truly values research. Number two, fully integrating research teams across academia and the NHS. Number three, providing dedicated research time for research active NHS staff. Four, ensuring undergraduate curricula equip healthcare staff with the skills to engage with research. Five, incorporating flexibility into postgraduate training pathways. And six, streamlining research through your R&D, through joint R&D offices. And I'm going to say a little bit about one or two of these. I don't think I've got time to go through all of them, but I'm going to focus on one or two of them. So next slide, please. The first was really about creating a system that values research. And I think this very much speaks to the cultural aspect of this conversation that we're having this morning. And we made various recommendations to the report. Again, I think some of these have been age-old demands from us within the research world that should be happening across the wider system, so that research should be the responsibility of every NHS trust board, that we should see work to build on, to develop research metrics, not just within trusts, but across the wider health and public health system. And I know that the NIHR prior to the pandemic had begun to pick up this question of research metrics, building on the brilliant work actually had done already with the Care Quality Commission. So one was about creating a system that values research. The second one was around, next slide please, was integrating research teams. And there are a variety of recommendations here, and I'm just mentioning this because not all the recommendations cost a lot of money. We felt that they're very clear, sort of very low cost or no cost, but quick wins we could be making, such as awarding honorary academic titles to healthcare professionals that help with career development, give them access to grant machinery and also supervision and career support, but also encourage mobility. So we felt that there was more that could be done, and not all the ideas around some of these focus areas are ones that need a huge amount spent on them. Next slide, please. I think the flagship recommendation, if I can call it that, within the report was really trying to address this issue around providing dedicated research time. I know time is a issue that's had caused much debate, and we're all very well aware of how increasingly stretched time is for healthcare professionals and others in delivering, trying to deliver research. And I know there's been some very good reports by the Association of Medical Research Charities and Cancer Research UK on this particular issue. So what the report proposed was the putting together of a pilot in a number of hospitals. We had York Health Economics Consortium to cost a pilot which would involve 6 teaching hospitals and 6 district general hospitals on the basis of, and the pilot was on the basis of 2020. So 20% of consultants who would be spending 20% of their time at research. And we asked them to estimate the cost of what that would be, and that's about £26 million. And that's very much the pilot we've been trying to push very hard with government to support, and I will come back to that. But essentially the message is here, we need to give people time, and we need to see that time ring fenced if we are going to support research across the system. Next slide, please. So the next 2 slides, rethinking undergraduate training of health professionals and incorporating flexibility in postgraduate training, is all around, I think, trying to modernize the career ladder, increase flexibility, enable researchers to gain skills in other areas that are going to be beneficial to sort of reflect the way that medicine and research are changing, but also enable healthcare professionals expose themselves to more research learning and research knowledge, and become converts to how research is important in the delivery of health. And I know from my previous role, one of the blockers, and if I can call it that, so I think the promotion of research is often the uninitiated, the naive health professional who is somewhat resistant to passing on the research message to patients purely because they don't have the knowledge to do that. And I think we can do a lot to change that together. So let's skip the next slide and go to the last one. And then I think there's a lot of structural things we can do. I know from my work with the network that R&D offices are currently overwhelmed, but we felt that were some efficiencies, perhaps some capacity to be gained by bringing together NHS R&D offices and HEI research offices into a single function. And I know in some areas that is clearly happening, and there are some examples of that in the report. So in the final 2 slides, I just want to say where I think, or where we think as an academy, the picture is currently, what the picture is currently looking like. So next slide, please. There are some clear, I think, opportunities. I think Frank said very, very well about how COVID has been a really important moment which research and science has seized to come together and do some amazing, amazing things. The comprehensive spending review is always a challenge, but it's also an opportunity. And going back to the pilot, we feel as though the pilot for research time might be gaining some traction within government, and so we would encourage people to really support that in their messages to government as something that's viable and something that will be beneficial in the long term. There also seems to be a huge amount of energy and drive behind the R&D roadmap and the wider research culture agenda, not just in health but across science. And I think what we're talking about today has to be very much part of that mainstream debate. And I think they can learn from what we're doing, and we can learn from what they are doing. So what I would encourage us to use that debate and that discussion as an opportunity. There's clear disruption to research funding and careers, which is worrying us a great deal. I think our colleagues at the AMRC are doing a fabulous job to try and secure a partnership with government, the Life Sciences Charity Partnership, which would enable those research careers affected by the drop in charity income. I think we really have to stay on it. I think my sense is there's a positive hearing within government, but we have much further to go before I think we see it emerge from any CSR process. But more widely still, we've been joining with other funders to make statements and to think about how we can ensure continuity in careers. And you may know that we have a support, part of our website that's there to support researchers whose careers have been disrupted and who are going through some significant trauma. I think we have to recognise the personal and the emotional impact on people. Clearly, the research agenda is difficult and complex, and we will probably come back to that in the discussion, and we want to do everything we can to support that. Clearly there's a very big and active debate about diagnostic testing, but I think one of the things that we have done in the academy is on Friday we convened a workshop of our fellows and others to look at this particular issue, and we identified, I think, some key enablers that are emerging where approaches to diagnostic testing, such as in Cambridge, are seeming to work. So the characteristics seem to be good leadership, a very collaborative culture, a flexible regulatory environment, and an embracing of innovation and a willingness to do things differently. And where those things don't exist, then of course there's real difficulties in our opinion. And then we hope to provide more leadership in this area. We are focusing very much on the regional agenda. I've already talked about Julie Williams as our regional champion, but in our CSR bid, we've asked for considerable investment in our own expansion of regional working, including development of regional hubs and promoting mobility between sectors. So we have a mobility scheme that we're about to set up, which will enable researchers to cross between industry, academia and NHS with our support and learning and become collaborators and facilitators. Next slide, please. Moving on to public involvement and engagement. You can take the person out of public involvement, but you can't take public involvement out of the person. So it would be remiss of me not to finish on this slide. But the Academy has always done some form of what I would call public dialogue, and particularly in its policy work. But we are committed to putting together a strategy and a much more robust approach to public involvement across all our work and in our governance in future years. But I think one thing we have learned from COVID-19 is how to involve and engage public and patients at the very highest levels and on some of the most significant challenges. So in April, we produced our report to identify mental health research priorities, and that included a survey of public members, but also we had public members of the working group who were also co-authors on the paper that we produced published in the Lancet. We developed a people's advisory group for emergencies. That was an idea that came out of one of our PPI meetings. And that was part of our report to look at the winter challenges ahead, which got a lot of press in June and July. And we wanted to do that because we wanted to demonstrate to the CMOs of this world and the chief scientists, and also to the Boris Johnsons of this world, that actually you can engage and involve public on the most significant high-level strategic problems. And they have something to add which is of value and can ensure our better preparedness for the future. And then finally, we've done a piece of work with young people, Planet Divock, which is a comic to help empower young adults to make sense of the coronavirus pandemic. It's just produced its 3rd issue. It's got another 3 to go. I'm not going to claim that I really understand what that comic is about. Despite reading it, you have to be under 18, I think. But it's a great innovation, and we're delighted to support it with our colleagues at Manchester BRC. So, Kieran, I'm going to finish there. I hope that's been helpful, and thank you again for inviting me.
That's great, Simon. Thank you. There were loads of questions that I can think of to ask, and I can see from the question box there are about 10 or 11 questions. Just a quick reminder, you can ask a question, but also just to the left of each question there's a little button you can click which sort of upvotes it, and then the ones that get the most votes are probably the ones that will concentrate. So many thanks, Simon. Shall we hand over to Usha? Usha, I can't see you, but I'm sure you're there.
I'm still here. Can you hear me?
Absolutely.
Okay, lovely. Thank you. If there's any problems with hearing me, please do sort of wave or something, and I'll keep an eye on the screen as we go along. I'm very sorry, everybody. You'll just have to excuse the fact that I'm a sort of a weird purpley blob today. It's really lovely to be able to join you all as part of the conference today, and thank you very much for asking me to come and speak to you about what I've sort of termed research culture and capacity, and particularly thinking about our role as a funder in terms of building resilience for the future. Like Simon, I'm going to give you a little bit of an overview of the Health Foundation and the things that we're funding and the way that we're thinking about our funding, and also tell you a little bit about how some of the pandemic shaped our thinking around research, culture and capacity and resilience. And although the presentation itself isn't about the pandemic, I think it is very difficult for us to really extricate our learning as a funder from it, not least because I think the pandemic stress tested the whole of the health and care research system across the whole of the UK. And I think it's demonstrated both its strength in its ability to be able to respond, but also its weaknesses. And where we think there are areas for highlighting a real need for step change. Could I have the next slide, please? Thank you. So the Health Foundation is an independent charity, and our mission is to improve health and healthcare across the UK. We do this by giving grants to those working on the front line and evaluating programmes and policy interventions, while also conducting and commissioning research, policy and analysis. What separates us from many of the other funders, perhaps, is that we're independently funded through an endowment and focus solely on health and its wider determinants. This provides us with a unique opportunity to connect what works on the ground with policy and vice versa. It also allows us to share what we learn with the wider sector and to collaborate with others to create networks to build people's skills and knowledge. And perhaps most importantly, we aim to bring the totality of our offer together to provide a strong and credible evidence base on which to achieve our mission. We have approximately 200 staff working on the development of programmes and funding, managing research projects or conducting in-house research and analytics. And I think this also means that we're uniquely placed to give a view on the whole of the research, policy and practice cycle, on which I'll draw some of our learning today. Could I have the next slide, please? As part of our work, we fund and commission research across 5 strategic priority areas, which are highlighted in this slide on the right. And between 2014-2019, we funded over 170 external research projects to roughly the tune of about £30 million across a range of activities, which are listed on the left. And within those activities, I think it's really important to note that we have a really mixed portfolio of funding. So we fund things for the short term through things like rapid cycle evaluations to help innovators understand the impacts of their innovations and also to support them to develop and refine their interventions. But we also do that alongside funding for the long term, whether that's supporting the adoption and spread of these innovations, or through understanding the impact of significant and substantial policies, such as, for example, the devolution of health and social care in Greater Manchester, or building capacity and capability in specific areas, such as our 10-year investment in this institute at Cambridge University. Whatever we fund, however, one of our underpinning principles is that we ensure that the research that we fund is highly applied and directly relevant to policy or practice, such as, for example, our long history of working on patient safety or our work on adoption and innovation across the NHS. These two components combined allow us to invest what is a relatively modest amount of funding per year by comparison to other funders into areas where our work can have real impact on a day-to-day basis, both in terms of policy decision making and also in terms of the types of programmes that are taken on to scale and spread across the NHS. Next slide, please. And although the Health Foundation is a comparatively small funder, nestled into a very much larger landscape, it is a key player in terms of its commitment and capacity to mobilise evidence into the mainstream, and in doing that bit of work around connecting the dots between research and implementation. I think this is particularly important, as Simon's already highlighted in his presentation, where in a world there's increasing evidence that organisations and teams that engage with research are more productive, where there's also a burgeoning evidence base for the direct link between NHS Trust performance and how research active they are, and increasing the recognition of the impact of healthcare research in terms of supporting the economic growth across the UK. Examples of some of the work that we've supported, particularly where we've worked with clinical teams and researchers, have included our work on developing patient-centred care and programmes of work such as PROMPT, a multi-professional obstetric emergencies training package for maternity staff in the UK, and PINSA, a prescribing intervention designed to identify patients who are at risk of their medications, which is currently being rolled out across England via the Academic Health Science Network. We've also done a lot to really link research up with practice, particularly through things like our Q community, which aims to connect clinicians and healthcare improvers across the UK and support people in the sector to access really good quality evidence on healthcare improvements and build communities of interest around what works. We're currently also doing work in exploring things like continuity of care in general practice on patient experience, and things like the potential role of social franchising on spread and scale of innovations across healthcare. But we've also stretched our wings a little bit over the last 5 or 6 years, and we're funding and continue to fund things like a group of multidisciplinary researchers focused on understanding what works in improving healthcare, but also pushing at the boundaries of data science, using things like rapid cycle evaluation to understand the impact of healthcare through our improvement analytics unit in partnership with the NHS England and Improvement. And we've launched our Network Data Lab, which is bringing together teams of advanced analysts to use linked data sets to produce insights in critical areas of population health and healthcare to help reduce health inequalities. We've also substantially increased our influence and commentary on things like health and social care policy through a combination of both our robust in-house and in-house analytics and also external research, which includes things like trying to understand the public perceptions of the NHS when it turns 70, and also our work on financial sustainability of social care. Could I have the next slide, please? Thank you. So what is the secret of our success so far? I think one of the things that the Foundation does, which perhaps places it in a slightly different position to some of the other funders, is that we really don't view researchers, policymakers and practitioners and clinicians in isolation. For each group plays a really important part in how we create and sustain change. We bring together different disciplines from across the social sciences, policy and healthcare systems, where we aim to combine things like economics with behavioural science to bring together policy analysis with clinicians and other health professionals. We draw our expertise from things like public health, local authorities, the NHS, and combine this with the latest thinking across other disciplines such as engineering, design and implementation science, and much, much more. We really see our roles as facilitator of change, of which research plays a really important and transformative part of it. And we recognise that career pathways and networks are as important as individual grant funding. And we understand that we have a role in not just providing funding, but also brokering the relationships between our award holders and the wider sector. And I think it's fair to say that over the last 18 years, we've learned quite a lot about what works in terms of building research culture and capacity. For example, we know that there's an often quoted phrase where it takes an average of 17 years for research evidence to reach clinical practice, and that it's generally assumed that reducing this time lag is a good thing. But we also know that in practice, it actually really underestimates the complexities of adoption and spread, and that the level of infrastructure which is needed to support this is substantial and significant. We also know that funding models, for example, when you're looking at things like innovation and adoption, don't necessarily reflect the fact that in this world that research doesn't sit in these nicely defined buckets, and that you can split it by specific and singular academic disciplines. And that for researchers working at the sort of the interface between research and innovation come from a variety of different backgrounds. And so what we try and do is combine our research funding with our innovation funding so that we can really test the changes that are happening on the ground in the real world through to the point of scale of spread. And a number of our current programmes of work can be traced back 10 years or more and have gone on to win awards or funding from other organisations. We also know that it's really important to invest in people and career pathways, and that despite individual things like fellowships and training opportunities, there's still a really significant gap in both the research understanding within the NHS and also the wider sector to both generate the evidence and understand it well enough to make judgments about how to best implement it. This can range from anything from evaluating a complex system through to really understanding data and analytics. And we are starting to look at and increasingly using models of funding where we encourage teams that are applying to our programmes of work to really think through what they want to do and what skills they want to get out of it, and look at how we can prime some of that through sort of training and development as part of not just the delivery of the programme, but also the application process. And we also know that if we want to support people to take up academic careers from whatever their starting point, we need to do this with much, much more nuance than just funding their basic research. Early career researchers need support through mentoring and coaching and opportunity to build networks. And we do this through extensive fellowship programmes designed to support and nurture people at the transition points within their careers. And we're increasingly looking at how we support and boost teams to really think about the differences between delivering change and also really using evidence to support that. And there's a lot talked about the levelling up agenda across the UK when it comes to research, but we're also increasingly recognising that levelling up doesn't just need to happen across regions and the nations of the UK, and that when we talk about research within the healthcare system, this needs to include things that are at the interface between health and other parts of other systems that impact it, most notably social care. And where we're working, and we are starting to work with partners such as UKRI, ESRC to help build the infrastructure needed to support the better evidence of use of evidence into practice in social care. So there's a lot that we've learned and there's lots that we do, but what else do we as research funders, commissioners and users of research need to do? You didn't have to go far on social media at the height of the first wave of the pandemic to see the importance of this close and joint working between researchers and clinical staff to mobilise both the UK's research capacity and its ability to feed directly into clinical decision making. The ability for multidisciplinary teams and multi-professional teams to produce and absorb and synthesise research at speed has been breathtaking and awe-inspiring. Funders mobilised quickly, researchers developed new collaborations, we engaged with policy in a way we haven't seen for decades. And I think when I looked at it briefly last week, even if you just look at the UKRI tracker, there was over £112 million worth of new awards alone. To date as of last week. I'm sure that's probably gone up since then. This infrastructure and this innovation and this support from funders, if I was being a little bit tongue-in-cheek, I would say is definitely world-beating and world-class. And I think this is a story of success that we should really rightly take time out to celebrate today at your conference. And as Simon has discussed, some of the structural challenges to making this happen are actually relatively straightforward to overcome if funders and the other component parts of the system can work together. And as long as the conditions are right for clinical and academic teams to work together. But it is just the beginning of the COVID-19 story, and it would be fair to say that as a funder we are concerned about the next phase and what we do to address some of this. And like all good stories, there is this catch and often a bit of a darker side. And COVID-19 has absolutely stress tested a number of our underlying models and assumptions across the research landscape and shone a spotlight on some of the things that, if we were honest, we knew were issues within our research culture, but perhaps we haven't actually made the progress at the pace we needed to, and that we're still trying to struggle to articulate and address some of the challenges. Could I have the next slide, please? So what are the things that we've learned through COVID-19? I mean, we couldn't have known exactly what shape or type of pandemic we were likely to have, nor when it would strike. But one thing the pandemic, I think, has absolutely demonstrated for all of us is how very little we knew or acted upon in terms of the way the world is currently configured and works. It's been hugely evident that we know that there's very little about marginalised communities across the UK, and that through system level unconscious and perhaps maybe even sometimes conscious bias, funding has actually routinely ignored the needs of the most vulnerable or sought to address inequality in the way that it's framed, designed, commissioned or delivered. This has been really evident from the top to bottom in the early days of the pandemic, and it continues now, although the media coverage of it has lessened, and has meant that we know very little about the impact of policy decisions, for example, in response to the pandemic on increasing structural inequalities, which will play out in the longer term on people's health outcomes. For example, how NHS staff from minority ethnic communities have been so adversely impacted by day-to-day decisions in practice. It's been felt really keenly across the system, and very much so in the NHS, where staff had to deal with the impact of COVID-19 on colleagues and communities in their care, and even more so within care home settings and in social care. I think it's also fair to say that suddenly things like impact took on a bit of a new meaning, with how to influence strategies, often including tweeting preprint research findings to large and diverse audiences. This is fantastic, and it's an absolutely golden opportunity to get your research out there. But I think it's also fair to say that uptake may not have always been with the same level of critique or research literacy that you would have hoped for, depending on who got the soundbite, and where hypotheses have become fact very and frighteningly quickly, rather than waiting for the accumulation of evidence through peer review and challenge over a significant period of time. I'm also concerned, and I think we are looking at this from a foundational perspective, although I suspect the levers for change that we have are fairly small, that we've built a higher education system based around fees from international students, which have underpinned core costs and research time and kept people on short-term or zero-hour contracts, which have been absolutely and disproportionately impacting researchers in their early part of their career, women and those with caring responsibilities, or those from ethnic minority backgrounds, let alone anybody who's at the intersections of any of those. And where clinical research is often carried out at the margins of already full-time and fully stretched roles, and not easily accessible to many outside of the main hubs of academic excellence, which my hypothesis is this may be leading to gaps in knowledge about how we respond to regional differences and how we really tackle some of the issues on the front line. And we don't yet know, and this also slightly worries me, that what the impact of a significant loss of face-to-face teaching time will be on researchers of the future, where things like bench time, particularly in things like biomedical science, are so important, and the impact on hands-on clinical practice in training and development of our young future researchers and clinicians, where it's so critical to shaping their skills and thinking. Nor have we really come to a sense or a conclusion how we as a research community and as a set of educators address some of these shortfalls in a time when we're putting all of our efforts into the here and now. And finally, I think one of the things that's also on our agenda as a foundation is that as researchers, we've often discussed the difficulties of translating research so that it's digestible for policymakers and politicians. But we were so suddenly thrust into the spotlight where ideas became truths and sound bites, where mainstream media have been reporting constantly, and where we're experiencing the real-time gap between the realities of what is actually slow science, that's how science is created, and a bit of a lack of research literacy in the way some of this is interpreted and communicated. That has really shone a light on some of the gaps as a research community where we've not been so well equipped or well resourced enough to address some of the challenges and some of the misinformation and sort of distrust of data that's been emerging. And as a result, we're living through a very natural experiment of how these gaps in our research culture and landscape are leading to increasingly confusing messages and public mistrust. could I have the next slide, please? So you'll be pleased to know this is my last slide, but where does this leave us? To quote someone who I admire greatly and who is at the forefront of their research career, but I won't name them because I've not asked them if I can quote them. We knew all these were issues, but I think we always thought it was someone else's job to sort them. I just don't think we realised the magnitude of the potential impact if we didn't get it right. And I genuinely think there's some truth in that statement. I think if we were honest with ourselves as funders, we knew that research agendas were being set by a comparatively small group of reasonably like-minded individuals, and that we probably weren't spreading our funding to look at some of the most deeply entrenched and challenging issues of our time. That despite moves and good intentions in the right direction, there have been and continue to be some really unhelpful silos between disciplines and organisations and skill sets. And although we're making headway in some areas, we're falling back in others, so rightly highlighted by Simon in his presentation today. And I think we have responsibility as funders and researchers to note these messages and to listen to our stakeholders. For example, in the past few months, I've seen a sea change in how people view our funding decisions at the Health Foundation, an open challenge on the representation of different voices on our panels and in the way that we design our research calls. And while as a foundation we have a way to go, as most funders do, I'm also really proud of the fact that the Health Foundation was already tackling the lack of voices around the table in the way it was designing programmes and its funding, and that we've been able to engage openly and honestly with the research community about our limitations and also the measures and steps that we're taking to really address some of this in the future. So as a foundation, we'll be pushing for more transdisciplinary research, not just within the NHS, but across those fields where they have a direct influence on our health, bringing in public health voices and different sectors, and aiming to really tackle the complex and wicked problems facing health in the UK, so that we can understand how those different elements of the system influence each other. We're beginning a programme of work doing just that, looking at how we can build consensus around the long-term research agenda in response to COVID-19, bringing together academics, policymakers across sectors and disciplines with the public to inform future funding decisions and ensure that we don't lose the sight of the impact of COVID-19 on all of our lives as we move forward from the pandemic. And we'll also be funding in ways which continue to promote opportunities for academics and policymakers in the health and care sector to work together, acting as a broker where we need to support both the uptake of evidence into policy, but also the dissemination of evidence into practice. We're developing an inclusion panel to support and shape our work on inequalities, where members will be both a core part of helping us set our research agenda in relation to COVID-19 and in also developing research where possible. And we're funding and supporting ever greater knowledge mobilisation and implementation through both our own work and our award holders. And we're increasingly looking at models of award management, whereby we're supporting those applicants to develop skills in evaluation and programme design as we take them through multi-stage application processes, and doing so much more to try and address some of these challenges. So in a nutshell, we see ourselves as very much as active funders. We're not passive. We don't just give money out. We're working with award holders rather than holding them at arm's length. And we see ourselves as playing a core part of really changing some of the debate around the research system. So the question for us is not really what needs changing, but rather what do we really need to do to make the change? Thank you.
That's great, Usha. Thank you so much. There's an enormous amount there in your presentation. And I think I saw a couple of questions earlier about whether we're making presentations available afterwards. And of course, the sessions are being recorded, but I'm sure Kate Myers and our web team can make the presentations available to people as well on our website. And by the way, a reminder that we've just launched our new website today, which is a brilliant update on what was a website that was looking a little bit 20th century and is now looking really fabulous. So we've got about 9 minutes or so for questions. We have run over a bit because we started late, and I hope everyone will forgive us doing that, but we will stick to the length of the session. One of the first questions or the most popularly voted for questions, if you like, that I wanted Simon and Usha to pick up first was about the relationship between health and social care research, and whether or not some of the changes that we're trying to make to bring academia and the NHS closer together actually risk in some way further sidelining social care and social care research. It's interesting. Health and Care Research Wales very deliberately adopted a name which reflected our responsibility for health and social care. NIHR hasn't made that change, but has recently, in recent years, made a big investment in social care research. But everyone knows how big that difference really is. So perhaps, Simon, would you like to comment first from the point of view of the Academy of Medical Sciences, which suggests you have a particular focus? How do you kind of get out of that silo?
Well, I think that's a very, very good question, and I would completely accept the critique that you might make of the recommendations, that they do look somewhat binary in many respects. And it's certainly a conversation that we've had within our council, that actually we as an academy, and I think probably many aspects and parts of the research sector, have to step out of their comfort zone and start to work with a much wider, more diverse range of voices, and begin to create and encourage that conversation. So I would absolutely applaud the question that's put up on the crowdcast to say that, and we would be very open to that conversation. In fact, we want to have it very much. So I'm not trying to cop out of a direct answer, but I think we would completely accept that we have to diversify and think differently about the work that we do, and we are becoming a broad church. And I think that one of the reasons that is so is because the profile of our early career research is very different, perhaps, if I can say it, to our current fellowship, and we have to respond to that.
Yeah, absolutely. Usha, do you want to say something? I mean, the Health Foundation has pivoted towards putting a lot more money into social care research in recent years, hasn't it?
Yeah, it has, and it is increasingly looking at social care as a huge enabler of health, which again we all know, but actually the action on social care has perhaps been somewhat lagging, not least in terms of funding just for fundamental care. But I think there's a couple of things that when we've been scoping the work that we've been doing in social care that's really struck us when we've been looking at the sector. I think one, when you've worked in the healthcare system for a very long time, as the Health Foundation has done, you don't realise what a lack of infrastructure there is comparatively within social care. So as you've mentioned, NIHR and ESRC and some of the other research councils and funders are really thinking about how they can build some of that infrastructure. But you are almost starting from an absolute flatline point with social care. There isn't the things like academic health science networks. We've got ARCs, which are supposed to be working in England with local areas and bringing in social care. We've now got policy research units, which are also supposed to be looking at social care. But these things take time. You can't rush infrastructure and you can't rush change. So even though the investments have been made over the last 4 or 5 years, we've probably got another 10 years before we can really reap those benefits. And that's that sort of notion of kind of slow science. Research is not a quick beast by any shape or form. So I think there is a massive disparity between infrastructure in health and infrastructure in social care research, which I do think leads to kind of this bias of we'll talk about healthcare research and social care, as opposed to really driving forward social care research, and let's have some health involvement in that. So there is something about balancing out some of that infrastructure and some of that development, and there aren't the same sort of career pathways for people once they're in a social care research world, and the numbers of social care researchers are comparatively small. So we're looking at ways with partners about how we can do some of that work and develop that, but I think there'll be time needed to test ideas and see how that filters out. And I also think the entry routes into social care research sometimes hamper its ability to be able to run at the same pace. So social care researchers tend to come from all walks of life. You have a clear sort of professional route for healthcare researchers to come in through things like clinical academic roles. There's intercalated degrees at undergraduate level and so on. For social care, quite often research doesn't happen until much later in an individual's career, and they may come at it from very different perspectives and different areas. And so again, as funders, I think we need to look at that and really think through what that means for the funding models that we employ to be able to support and build capacity and capability within the social care research sector.
Yeah, I think there's lots there, lots more. We could actually, I think, run a session that would focus solely on the social care research landscape. And I know there's work going on between the ESRC and the Health Foundation to support development of the capability to use research in the social care sector, because it's not just about building more capacity to do social care research. It's actually about creating a system that then takes that evidence into policy and practice. Got time for one more question only, and they have to be quite brief answers. answers to what is a huge question. It's the second most popular one, and it's really about the relationship between universities and academia and the NHS. You know, someone saying that research is money in and money out for universities. It's teaching that brings in the income, a point that Usha and I think you also, Simon, alluded to, the fragility of universities. What's the ideal relationship we should be trying to create between universities and NHS organisations as partners? And where should the focus of research be? Should it be more in the NHS than perhaps in universities?
Usha, do you want to go first on this one?
Oh, yeah, I can. I think, Simon, this probably is sort of more your area of kind of expertise, I think, in terms of the NHS and where it should sit. I think we're at a very precarious position around the relationship between universities and research money. I think that's the point that I was trying to make in my presentation around what are we doing and how are we addressing that now? Because we may not see the impacts of the decisions that we make now and for another 4 or 5 years in terms of how we're supporting this. I think the money in, money out issue is one of the challenges with the current funding system. And one of the things that I know, for example, other funders like Wellcome have been looking at is how you invest in a person's career rather than invest in short-term grant giving. Because I think the nature of 3-year grants means that you are, or even 2 or 1 year grants, means that you're constantly looking for additional money to kind of effectively justify your existence within the academic sector. And I think that's particularly problematic on a number of levels. I think, one, it puts an awful lot of early career researchers or people who are transitioning into research from another role off, because I think they don't know whether they're going to have security in the work that they're doing. I think it has problems in terms of enabling people to really follow trains of thought in terms of research. You know, research, quite often you get to your final year of your grant and then that's when you start to find the interesting findings, which may or may not lead you to another award, depending on whether the priority of the funder has changed or not. So I do think there's a bigger conversation that needs to be had across funders around some of that. I think we also have to really make sure that as funders we understand the relationship between core costs and student costs and research. And I'm not convinced yet that we're having a particularly honest conversation about the balance of where some of that sits. And the impact particularly of the reduction in international students' fees and what that might mean going forward. So I do think there's a bit of urgent work around that.
Great. Simon, I'm going to give you the final word on this because we are now just running over time, but over to you.
So a lot of what Usha has said I would completely agree with. Just to build on that, perhaps with some of the softer items. So I don't think you can say research has to happen in the NHS as opposed to universities. I think that would be a disaster. What you want to create, I think, would be and to use the current disruption in the system to achieve is mutually beneficial partnership between the two. That's really where we want to get. However idealistic that might sound, I think that is the right objective. I would say that one of the key things is actually leadership. The actual question asked on the board is around what can clinical academics do. And I think this is where people need to step in as leaders and begin to create the culture, the behaviours that are going to engender that partnership. And I think that doesn't always happen. But I think this is the opportunity to do that. And I think the actual outcomes could be far better for us all. And hopefully they might use our reports as part of their manifesto internally to create that culture. Absolutely. It was your first bullet point about the sort of aligned strategic purpose, if you like, of the NHS organisation and its university partners, and both having a shared common value in research. We are out of time. Simon, Usha, thank you so much for your contributions. I hope the 372 people who've been on have enjoyed it. We're now going to give you all the opportunity to go and find yourself your own cup of tea and muffin or cookie or croissant or whatever. I'm afraid we're not providing those this year. The next session starts at 12 noon and it is focused very much on COVID and the research response, which has already come up in our discussion. It's going to be slightly different in it's a round table rather than having presentations, but I hope you will join us for that. So thank you everybody for joining. Thank you, Simon and Usha.
Thank you.
Pleasure. Have a
pleasure. Bye.
Bye.
Bye everyone.